Perfect, and we are live. That's all good. I've got my notes. Hi everyone, and welcome to another episode of the Foot and Ankle podcast, recently renamed for all of you paying attention. And I'm going to start that again, sorry. I got an intro and now I'm doing a new one. Hi everyone, and welcome to the Foot and Ankle podcast, the recently renamed Foot and Ankle podcast. For all of those who have noticed, blame Google SEO. My name is Alex Murray. I am the rehab podiatrist, and I'm really excited today to be joined by someone that all podiatrists should know, and pretty much everyone in the foot and ankle should also know. Anyone who's dealing with especially ankle bracing. It's Dr. Doug Richie. Doug, thanks for joining.
My pleasure, Alex.
So if we assume people haven't heard of your work, where have they been? Can you give yourself a bit of a brief introduction of who you are, your training, and yes, what you've done?
Okay, I'll try to be concise. I'm a podiatrist. I graduated from podiatry school in 1980. I did a surgical residency and opened up a practice afterward in Seal Beach, California. And all along in my training, I was focused on sports medicine, and my practice focused on that, and my I guess recruitment and marketing of referrals in my community always focused on active athletic individuals. Along the way, I developed a custom ankle foot orthosis, which subsequently became named the Richie Brace. And when I designed that brace, it was really indicated for chronic ankle instability and as a prophylactic brace for active athletes returning to sport after injury. It wasn't long after it was being used by podiatrists in the United States that I began getting reports anecdotally that the brace was very effective in treating, at that time, what we called posterior tibial tendon dysfunction. And I was quite surprised. I actually initially told doctors, well, don't use the brace for that. It wasn't designed for that. Then I stopped and started looking at articles and studying the condition, which I was familiar with, but I wasn't nearly as expert in that area as I was with chronic ankle instability. And as I learned about coupling between the foot and the leg and the massive internal rotation of the tibia and fibula in adult acquired flatfoot, I realized that this brace, by just almost coincidence and accident, was perfectly designed to control the deforming forces. So it forced me to go back and study the pathoetiology of adult acquired flatfoot, and it led me to become, I guess, somewhat of an expert. I was asked to author what became 2 chapters of 2 textbooks on the condition, dealing with the biomechanics, the first chapter, and subsequently I wrote a chapter on orthotic stabilization, both foot orthotics and ankle foot orthotics. So over the past 30 years, I've become very interested in and deeply involved in adult acquired flatfoot, and recently collaborated with a group of surgeons in the United Kingdom to publish a paper in an orthopedic journal proposing a new, different classification system for this. So in a nutshell, that's why I'm here, I think.
You summarized exactly why I brought you on, because yes, a couple of episodes ago we had Professor Peter Malliaras come on to talk about the posterior tibial tendon, and really the tendon quite specifically. And then when we started to try and talk about the underlying adult acquired flat foot, or what we're going to talk about, progressive collapsing flat foot deformity, he was sort of like, I leave that to podiatrists, and I was like, well, I know who I want to talk to next about this. But it was so interesting. That's so interesting to hear, because I guess I've in my career coming across the Richie Brace, it's always been, oh, that's the adult acquired flat foot brace, like that's and it always seemed very purposeful. So I guess that's always quite nice to hear someone is just like accidentally develop the right thing. It's not everything is completely purposeful, but you've
Right.
taken advantage of when of when it does
Absolutely.
go that way. You touched on something as well, just in your introduction, which is probably good to talk about before we dive in, which is you are a podiatrist, but you're based in the US and you have surgical training, which is not something that in Australia we have by default, and in places like the UK, surgical training is a much advanced point. So there's actually a difference between podiatrists, different countries. Can you sort of give a bit of a summary of the main differences as you see them?
Well, okay, to answer your question, all podiatrists in the United States are trained to do foot and ankle surgery because all podiatrists in the United States must do a residency program after completing their 4 years of podiatric medical school. And the residency training is 95% focused on surgery, both trauma, reconstructive surgery, and surgical wound care. So we are all trained in surgery. Depending on the level of the training program you went through, often dictates whether you ultimately become board certified, which is another level of, it's not a level of training, it's a level of demonstration of expertise, which I happen to be able to have passed my boards 5 years after finishing my residency. Um, and it varies from state to state what the scope of practice is, but most podiatrists in most states in the United States have privileges to do reconstructive rear foot and forefoot surgery, and many of us have privileges to do ankle surgery, including ankle fracture, and depending on your training now, total ankle joint replacement. Um, Interestingly, from my standpoint, I didn't really think I would do that much surgery as a quote sports podiatrist, and it actually was true. But as I became more and more a quote expert in adult acquired flatfoot, I started getting a lot of referrals. And by the end of my clinical practice, I was doing as much flatfoot reconstructive surgery as any podiatrist, I think, in my area or maybe even in the United States. So much of what I may share with you today is drawn upon a very vast surgical experience as well as my own biomechanics training.
Mm. Which will be great because there's definitely two sides. But I guess it's great to get that overview because when a lot of people come in contact with podiatrists, if you're in the UK, you're in Australia, even many other countries like Singapore, we are more allied health. We are not surgically trained. We're much more akin to on the level of a physiotherapist, whereas in the US it's much more guys are much more aligned with orthopedic surgery that does some physician level skills rather than. So it's a good difference because I have a lot of people definitely on social media when I post things, if it ever makes it this way to the US, get very confused
Yes.
at some of the comments I make because of the hyper focus you guys have on foot and ankle completely because of that hyper level of surgical training.
Well, what's sad, Alex, is that most younger, recent graduating podiatrists have completely lost their focus on conservative management of many of these conditions, specifically adult acquired flatfoot, and so they lack expertise, and more
Mm.
importantly, they lack any interest in implementing conservative non-operative treatments for adult acquired flatfoot. I wish we had more podiatrists who, like you in Australia and like those in Singapore, although they're limited in their ability to do surgery, are so highly focused on learning more and properly implementing non-surgical treatment for this condition, which is successful at least 70% of the time, and completely takes away the need for surgery in most of these patients.
Mm. Which is a good start because I mean we've had those discussions over email before about the state of training, and we could do a whole podcast on that, I'm sure. But I guess if we start talking about the condition, so previously known as posterior tibial tendon dysfunction, then got sort of more well known as adult acquired flat foot deformity. That's kind of more what I've sort of been introduced to it as. can you give a brief overview of the condition that we're talking about, and then we can sort of get more into the weeds of what this new framework is?
Well, and before I start, I meant to tell you I'm going to do this. I'm going to promote my book, in case some of you, but this is published by Springer, Pathomechanics of Common Foot Disorders, and you can order that online. I devoted a whole chapter to this. And before we sat down today to talk, I went back and reviewed the chapter. I was actually quite impressed with it. I forgot how much work I put into it. And I went into the history of this, and it's quite interesting that nobody really discovered posterior tibial tendon dysfunction until the early 1980s. There's just a scant few publications beginning back in the late 60s and 70s of patients who either had a spontaneous rupture of the posterior tibial tendon without any previous trauma. And one particular author named Goldner, an orthopedic surgeon in the late 70s, who was very much ahead of his time, attributed this whole disorder to a progressive ligamentous failure of the ankle and hindfoot. But his work and the work prior to 1980 were ignored. And suddenly you had people come along like Kenneth Johnson, Strom, Josh, and Meyerson, discovering that these adults with very pathologic collapsed flat feet were really the victims of a rupture of the posterior tibial tendon. And they described many case histories, and they described initially a surgical procedure that would repair the posterior tibial tendon, and then later described how 90% of those patients failed, which should have been brought a warning that maybe this isn't just due to a simple tendon failure. But time went on and progressed where they decided there were patients who didn't have a ruptured posterior tibial tendon who had a progressive flat foot. And that new terminology, adult-acquired flat foot, was coined by Meyerson in the early 90s. And then the recognition of spring ligament failure followed, and then the recognition of multiple ligamentous failure, and finally, more recently, the proposal of a new classification and a new phrase called progressive collapsing foot deformity. But in a nutshell, it's been an evolution over approximately 40 years, which is a relatively brief period of time, and at least 600 to 700 manuscripts published in the orthopedic and podiatric literature on this disorder.
That's really, really interesting to sort of hear the history. I always forget the quote, but it's sort of like history. History doesn't explain what happens. History explains what we're seeing today. And it's interesting because when you do a lot of reading on the condition where you're looking at the posterior tibial tendon and this hyperfocus on the tendon, it makes a lot of sense now when you think about it. It started in the 1980s, and this hyperfocus on the tendon, there's a hyperfocus on surgery, there's a hyperfocus on repairing the tendon, and it makes sense as that that's sort of what informed all of this ideas of the foot's collapsing, it must be the tendon not holding the arch up, because that's kind of the history. And it's only really recently that we've started to, well, interestingly, I think there was in 2000, there was Wenrub and Halala who tried to say, hey, look, it's probably not the tendon, it's the ligament. But it was kind of that history and that focus on the posterior tibial tendon, their classification system, or their attempt to try and redefine it didn't work, because everyone was just so focused on the tendon. But it's interesting to hear it's that, yeah, we're much more focused on the ligaments and the collapse or the instability of them that then causes that flat foot as part of it, and then the tendon's almost reactive to that.
Well, that's the new, at least that's the thought process that we proposed in our recent paper, but we certainly weren't the first. Even Meyerson's, the progressive collapsing foot deformity, emphatically state in their multiple papers that this is not a condition that is precipitated by tendon failure. The tendon is really an innocent bystander. But Weinraub was really one of the first to propose that, and he's a podiatrist. And that may be why a lot of the orthopedic surgeons didn't notice it, because it was published in a podiatric journal.
Again, yes, history tells us a lot about how things currently are. Can you talk a bit more about so we've got this, adult acquired flat foot has, traditionally a lot of stages. Probably what people are most familiar with is this grading system of, stage 1, stage 2, stage 3, stage 4. Stage 1 being, you've predominantly got a foot that is mostly just has posterior tibial tendon issues. Whereas, stage 2, sort of, you're starting to develop a flexible deformity, so the foot's flattening, it's quite flexible. Stage 3 being the deformities becoming more fixed, and then stage 4 is a progression of that fixed deformity. Now, and it's all sort of, it is based around, in some degree, the level of collapse of the foot and how the type of deformity that's there. Can you talk about this new progressive collapsing flat foot deformity scale and how it differs to the adult acquired flat foot grading system?
Meyerson et al., who proposed the progressive collapsing foot deformity classification, and then our group, we both abandoned a stage 1 posterior tibial tenosynovitis because we felt that suggested that was the first step in the progression. And most experts today agree universally that is not the first step. So we eliminated that as a stage 1. I think quickly the progressive collapsing foot deformity and the classification systems prior to it, after Johnson and Strom, but prior to our system, they're really proposed by surgeons, and they're based on static deformity and primarily on radiographic findings. Other than comparing flexibility versus rigidity, all of the findings are based on standing radiographs, static radiographic measure. And one reason for that is that's what orthopedic surgeons use to plan surgery. That's how they plan surgery anywhere in the body. They look at static images and they decide how they're going to do a procedure to make that image look better. And there's a lot of shortcomings to that, particularly in the adult acquired flat foot, because what the radiographs fail to do is show you what soft tissue structures failed that ultimately led to these shift in skeletal segments. I think with weight-bearing CT, we've opened up a whole new opportunity to really look at not only the level of deformity, but the underlying cause of that deformity, which I'll get to in a minute. I know you asked about classification systems, but in short, I think we have to be very careful of all of the previous classification systems because of their shortcomings, in the sense that they're based primarily on plain radiographs and on two-dimensional relationships of segments of the foot. The progressive collapsing foot deformity classification is very, very simplified into ankle, hindfoot, and forefoot, and it's basically transverse plane and frontal plane changes. No explanation of how it got there, no explanation of really specifically what surgical procedure would need to be done to correct that. It's just classifying based on radiographic findings. What we tried to do in our system was say that there is an underlying event or pathology that predisposes to these progressive changes. And in our opinion, it's joint instability. It's instability of the combined talocalcaneal navicular joint complex. Not the subtalar joint, but that joint complex that includes the head of the talus, the navicular, and the sustentaculum tali, or middle and anterior facet of the calcaneus. That's where all of this is happening in both the pediatric flat foot and the adult acquired flat foot. This segment of the foot is also known as the coxa pedis. according to a group of Italians, because it looks so much like the hip joint complex. It's stabilized primarily by ligaments, and these ligaments include the spring ligament as well as two segments of the superficial deltoid ligament. And there is an underlying laxity of those ligaments and perhaps an underlying osseous deformity in the shape of the bones around those articulations that leads to an inherent instability, probably in childhood, carried off into adulthood, that leads to ultimate ligament attenuation and ligamentous failure and progressive collapse and peritalar subluxation of the bones in the foot, rotating around the talus itself. And that's what our classification system describes.
Yeah, it's very interesting because it's immediately sort of going to the point of, first of all, it's describing the foot. It's segmenting it out into the different areas of the where you're seeing changes of deformity. It's focusing on the actual, what we think is the actual cause, not almost in a way what the other classification systems were doing, which is almost trying to classify people for different surgical procedures more than anything else. And it's not sort of rooted in that treatment focus. It's just a better understanding of the condition. And it's interesting because it is that focus on ligaments, but I also was reading about as well, is there this osseous, the way that the bones are shaped, that might predispose people to developing this condition, which I thought was also very interesting. Can you sort of talk a bit more about, well, I guess before we get to what predisposes people, I guess is the progressiveness, because it is all of the systems are based on gradings, and that the implication is that people can go through the grades or get a progress through. Do we always see that people, when they develop, their foot starts collapsing, they're getting this ligament injury or instability, that they will progress to higher stages, or do people just develop one stage and stay there? What's happening? Because it's interesting, because when I was talking to Professor Malliaras, he was sort of talking about how not everyone does progress.
Absolutely right. They don't. And what we were careful to point out in our paper is that there are no predictable stages of progression. And Meyerson and his group also recognize you can have patients that have acquired forefoot supination deformity, and you can have patients with severe hindfoot valgus who never get acquired forefoot supination deformity. So it's not entirely predictable. But I think everybody agrees that an underlying instability of the spring ligament precedes changes that can occur, whether it's in the medial column of the foot with attenuation of the plantar ligaments of the navicular cuneiform joint and the first met cuneiform. When those attenuate, the medial column flattens in the sagittal plane. It basically dorsiflexes on the rear foot and acquires this supination deformity of the forefoot. And then we will see some patients develop attenuation of the subtalar ligaments, the interosseous talocalcaneal ligament and the cervical ligament. And in those patients, the calcaneus subluxes laterally, and that's when we get to see this sinus tarsi impingement and subfibular malleolar pain that presents in patients. And we felt that was important to talk about symptomatology as a hint for the clinician as to what ligaments may have ruptured leading to that. In other words, when you have a patient with sinus tarsi impingement and pain that emanates laterally from the ankle and the sinus tarsi, you can be pretty sure they've lost the integrity of the subtalar joint and the interosseous talocalcaneal ligament. You should always look for forefoot supination deformity that's reducible, and that tells you that ligaments along the medial column have attenuated. So our clinical exam, not just radiographic exam, can be really helpful in determining the underlying pathology. Now, whether it really dictates our conservative treatment approach, I'm not so sure, because our non-operative approach is really a multifaceted um, approach to stabilizing every part of the foot that we can, and assume that most of them have been affected in one way or another, and try to figure out a way to stop it and maybe even reverse it.
Mm. That's actually incredibly interesting as a shift. Two things there. One, that potentially we're looking at the condition is not just being this one sort of set of everyone's going to look the same, the flat foot's the same, the collapsing's the same. It sort of hints that almost that you'll find that people may progress or not progress based upon the ligament lacks, like different how their foot reacts, which then implies how the shape of their joints are. That might implicate how again their foot collapses. But I think the sort of the bit at the end was quite good, where you can go, we have all this interesting information, it's all really great, we're learning all these awesome things, but at the end of the day it might not actually change. We sort of we hit it with a big hammer in terms of our conservative treatment, that we might not need to get into the weeds, which I think is an important distinction, because I think sometimes clinicians do get into the weeds, which is kind of really good that we get interested and we want to learn more. But then ultimately at the end, it doesn't change practice.
Yes. And it's not to say, for example, with a brace application for this, if I have a patient with significant sinus tarsi pain, I'm definitely going to do some strategies in the heel cup and footbed of the AFO or the Richie brace to try to bring inversion torque to the calcaneus and try to decompress the sinus tarsi, with a medial heel skive, with a much deeper heel cup than normal. If I know the spring ligament is attenuated, I'm going to try to adduct the forefoot on the rear foot as far as I can using an extended lateral flange. So if the medial column is unstable due to ligamentous instability, I'm going to plantar flex that medial column as far as I can during the casting procedure and try to restore at least alignment of that, so that hopefully ligamentous integrity will be restored. Uh, that's the one controversial thing, Alex. I've lectured on this for 30 years, and I'm convinced in treating hundreds of patients myself, and interacting with a lot of really astute clinicians, I think many of these ligaments can heal after they've torn or attenuated. I mean, we know ligaments heal in other parts of the body. We know the anterior talofibular ligament can heal after an ankle sprain. Why can't the spring ligament heal? Why
Well, the
can't the
ACL.
yeah, well, yeah. Why can't the interosseous talocalcaneal ligament heal? I know it heals because why do my patients become asymptomatic after bracing and actually can discard their brace and remain asymptomatic 5 to 10 years just with foot orthotic therapy? I mean, something must have stabilized in there, and it must be the ligaments.
Mm. So that's actually like a really good point that you're making with when it comes to conservative treatment as well. We're sort of going to hit it with a big hammer in terms of covering all aspects, but there are sort of smaller points to how we would treat it, maybe using this classification system, or just bringing what this classification system will bring to light in terms of our focus on this different deformities. Before we get, because I want to ask you specifically about, the orthotic prescription and bracing prescription, can you talk about the overall sort of management? So someone comes in, they've got a foot that is flattening, that is, so we've got someone, generally they'll present probably with posterior tibial tendon pain as well, but maybe they won't. They've just got a foot, they know that it's flattening, and you're going, I suspect that it is, there's asymmetry, suspect that it is progressive collapsing flat foot deformity, adult acquired flat foot deformity. What's the overview on treatment now that you've identified that they do have ligament instability. They do have this maybe not progressing to later stages, but it has progressed from their foot has changed. What are we doing for that specific patient, knowing as well that they are also generally, again from the discussion with Peter Malliaras, older, generally older, 50s and above, and have this progressive this change.
Yeah, and I listened to that podcast. It was very good, and I liked a lot of what he had to say, which I agree with. Before I get to the treatment, I'll just say you really, as a clinician, should recognize that when this patient presents, they're really potentially a patient for life, and they have a condition which will require a lot of their own attention and commitment to initially in order to recover. And I learned early on it's very easy to scare a patient off because you over dramatize it or you overemphasize the severity of it because in your mind it is severe and untreated how disabling it could become. But I think you have to be really careful in your education process at the initial interview of a patient to not scare them away, but rather um, gain their confidence and gain their commitment to getting well and certainly to avoiding surgery. And I think the first visit, it's incumbent on you to educate them fully about what you've determined is wrong and what it's going to take to get them better. Win their confidence, you need to do something on the initial visit to get them out of pain. And whether that is putting them in a walking boot temporarily. What I often did was strap or tape the foot and ankle because it's amazing how pain relieving that can be, even temporarily. Because if the patient walks out of the clinic feeling better from a temporary taping, it's a huge step to winning the confidence.
Mm.
And in a sense, that's why they came to you in the first place. They probably had no idea that they have a lifetime disabling condition. They're just looking for relief of pain, and you're obligated to give that to them and win them over. So don't forget to do that. And I'm a big fan of strapping and taping. And from my sports medicine days, I became really good at that. And I can tape an adult-acquired flatfoot and relieve most of their pain and have it work for several days before having them come back in. Um, the second thing is you have to realize it's a global condition. And I appreciated early on, I met and actually did some collaborative work with Cornelia Kulig, who's a PhD physical therapist and researcher at the nearby University of Southern California. And she published really the first quality paper on rehabilitation of posterior tibial tendon dysfunction using comprehensive approach from the hip down, really as a physical therapist, but also combining it with foot orthotic therapy and showing that at least 50% of her patients with stage 2 posterior tibial tendon dysfunction became relatively pain-free within 6 months. And I met her at a conference, I heard her speak, and then I corresponded with her, and then I followed subsequent papers she wrote. And I realized how important it was for me as a podiatrist to partner with a skilled physical therapist. And fortunately, in my clinic, I don't know if they were there, Alex, when you visited me, but we brought in a husband and wife team physical therapists who focused only on primarily on foot and ankle, who were part of our practice for the last 20 years I was there. And they were really an important integral part of our comprehensive approach to adult-acquired flatfoot. And we had to explain to the patient, I'm going to make you a brace, you're going to need to buy proper footwear, and you're going to need to follow through with this rehabilitation program with our physical therapists, including home exercises. And if you do, you can avoid surgery. And if you don't, I do this surgery, but I can tell you it is not a pleasant experience to go through. And I'm going to do my best to help you avoid it.
Mm. So yeah, the treatment was really we're sort of looking going. You've got this dynamic ligament instability, and if we're a combination of both protecting it or holding the foot, thinking about a brace to essentially stop it moving more, and then the combination of then actually within that brace getting them to move more and more and more. And the interesting thing was, you know, two ways to look at it. You've got, you know, hip exercises and knee exercises and looking at the whole lower limb and going, okay, are we, you know, exercising more and getting them moving more is one way, because they can start to then exercise, reintegrate into the day, and potentially address. I know that there's other things that you've brought up, like metabolic conditions, you know, in your work that may be impacting why this comes out, why we get some ligament instability, but also starts to essentially guides them towards actually using their foot and ankle more rather than protecting it. So you are sort of protecting it with the brace, then getting it stronger. And then, you know, as you said before, you're trying to get them out of that brace and sort of progressively loading the ligaments. And that sort of to your point about them healing is, and we see this in ankle sprains, we see this in ACL, that you want to actually start to load the foot. So you're sort of dealing with maybe this whole approach gives you the whole person focus, getting them moving, getting them enjoying their life, and sort of starting, you know, helping them sort of see, yes, this is manageable, but at the same time, you're also sort of locally trying to load it. Is that a sort of a good overview of sort of what you're achieving with this?
Absolutely, and I think it's important to emphasize the positive changes that will occur from all aspects of the program. I mean, let them know that you're going to go through this rehab program and you're going to have a better quality of life afterward. Not just because your foot doesn't hurt anymore, but you're going to be more stable. You're going to have improved balance. You're going to have a much more active lifestyle. When I dispense the brace, the first day I say, our goal is to get you out of this brace. This brace is not meant to be worn the rest of your life. Everything that we do has a positive spin on it, because adherence to the program is critical to its success.
Yeah, and I guess when you're talking about the brace and we're talking about the ligaments, your goal is to try and get them out of the brace and the ligaments healing. I guess one way to think about the condition and this flattening is that it's potentially, we're looking at someone comes in, their foot's flattened, we're identifying that it has flattened. There's all that bone contribution, the ligament instability contribution. They've gotten into a point, and what you're providing is, once the ligaments, that it might not progress to later stages, it might already just be in the stage that it's in for a long period of time, but giving them the dynamic stability of the ligaments by allowing them to heal kind of has that impact on everything else, that they will become more stable on their foot, they will start to be able to get stronger. Is that kind of where that sort of fits, rather than looking at it as they're the ligaments are, you know, damaged, unstable, and it will always progress in terms of to a later deformity because they are unstable?
Exactly. You said it just perfectly. I mean, without treatment, most patients progress. Some don't, as we talked about earlier in this. There's some patients who start breaking down, and then for some reason they stabilize. Maybe the ligaments healed on their own, who knows? But our goal is not to restore the arch of the foot. We cannot make that foot cosmetically have a normal or high arch again. But what we want to do is have a stable foot and a non-painful foot and a non-progressive foot. You and I know we see lots of patients with very stable, asymptomatic flat feet. And the reason people have asymptomatic flat feet is because they have intact ligaments. They have stable joints. The foot is flat, but it is stable. And the stability is provided by ligaments that have regained their integrity. And that's our goal with this treatment.
So to speak on that specifically, so someone comes into your office, you've set the expectations, you've talked to them about the rehab, but you've actually now got to make an orthotic and a brace, or you've done the taping as well, but you're now making the orthotic or the brace. What are you doing specifically at different sort of points in time? What's changing your decision making? Like, when would you choose a foot orthotic over a brace? Does everyone go into a brace for a certain period of time? What are the features of the orthotics or braces that you would be putting in?
Yeah, that's a really good question that I get asked, and I've actually given a whole lecture on that. Keep in mind that, first of all, at least in my practice, at least half of the patients who presented with a symptomatic progressive adult acquired flatfoot deformity were already wearing foot orthotics. For various reasons, they'd received foot orthotics earlier in life because they had, quote, flat feet, or they may have been treated by a neighboring clinician who just was failing with the treatment. They'd slapped a pair of orthotics in the shoes and didn't do anything else for the patient, and of course, they didn't get better. So those patients already, well, a foot orthotic didn't work. We're going to have to move to the next level. You go to a Richie Brace. But other patients would present that had never been treated with a foot orthotic. But when we evaluate them, we know the foot orthotic is going to fail just based on at least my own clinical experience. And to put it succinctly, if a patient is unable to perform a single foot heel rise, in my experience, they're going to fail with custom foot orthotic therapy, because the inability to perform a single foot heel rise indicates a very unstable midfoot joint complex, probably due to rupture of the spring ligament. And at that stage, a foot orthosis will not control the tibia, will not control the massively internally rotating tibia and talus. If the patient can perform a single foot heel rise, and there isn't significant sinus tarsi pain and impingement, subfibular impingement, I would definitely go with a custom foot orthosis first. Sometimes there's economic factors that play into it. You charge a patient a bunch of money to make them custom foot orthoses, it fails, and now you're going to come back and charge them the same amount or more for a Richie brace. That's a tough thing for a lot of patients to accept. And I would say if you have to roll the dice, we'll go with the Richie brace because it has a much higher chance of working across the board for adult acquired flatfoot. But if you have a patient who's willing to spend the money, or there's insurance coverage, like here in the United States, we might try a foot orthosis first. But a foot orthosis is effective in only very early stages of adult acquired flatfoot, and the spring ligament has to be intact, and the foot has to be quite functional for a foot orthosis to work.
Because it's recognizing, because if we're thinking about the deltoid ligament, it's recognizing a chunk of what that deltoid ligament is restricting is internal rotation of the tibia.
Yep.
But once that deltoid ligament is lax, or it's not performing as well, that internal rotation results in a lot more forces through the rest of the joints, and that kind of creates more of that pressure on sort of more distal ligaments, and that's sort of what you're talking about again, as well as once you get that talonavicular joint, it's starting to progress. You're getting that failure around that joint. We're getting potentially that progression and change in those other surrounding ligaments, effectively, because if we're thinking about the talonavicular joint, it's the sort of the top of the bridge. It's sort of what's holding things together. Once you take out the stability of that keystone, it will have a rippling effect on the other things of the other ligaments, because it's got that pressure, that extra pressure from that biomechanical position, if I'm correct.
Yes.
And understanding correctly, and that's where the brace sort of just is kind of the big hammer we were talking about, in the way that it just holds everything together, resists the internal rotation by coupling the leg to the foot, if I remember having seen you speak on this a number of years ago.
Correct.
So in terms of, so you have someone come in, and then you're focusing on setting the expectations but not scaring them, giving them some taping, and then saying, hey, look, this is sort of a good, in a way, a test to sort of confirm. You say, this is what I think is going on. If we do this, it should improve a bit, but these are all the other implications. And, you're showing that you can get some pain relief. And you're sort of going, okay, look, probably you can't do the single leg heel rise. You're a bit more further down the track. We probably need to do this brace, a Richie brace, what expectations are you setting around in terms of time frame, and is there an expectation you would set that might be different based upon their current condition?
Yeah, that's another great question. The answer, Alex, is no. There is no set time frame. I'm amazed that some of the patients that were the most symptomatic on initial presentation were the ones who responded the quickest to treatment. And there were many patients with very mild symptoms and even mild deformity who took much longer to respond. The bottom line is, in my experience, effectively bracing them minimizes their symptoms usually within 2 weeks, which by no means means they're healed, but they're markedly improved in symptomatology within 2, if not at the most 4 weeks. But we've learned from other ligament studies, particularly lateral ankle ligaments, that these ligaments take a minimum of 6 months to really fully heal. And I think the spring ligament and the deltoid ligament complex probably heal even slower than the lateral ankle ligaments. So the general timeline is, I tell all patients, you're going to be braced for a minimum of 6 months. It has nothing to do with whether your symptoms get markedly better. Regardless of whether you're asymptomatic, you're going to stay in the brace a minimum of 6 months, and you're going to complete this comprehensive rehabilitation program, which is 12 weeks. So that's 3 months right there. We really use pain, much like in tendinopathy. We use pain as our guideline as to when to begin weaning them out of the brace. And we will do intermittent periods of several hours of the patient going out of the brace, but they're always using a custom foot orthosis and proper shoe. And they're using pain as their guideline. And it's very clear. Patients have an almost immediate return of pain within hours, or they have little to no pain. And as long as they have little to no pain, they begin to increase those time frames out of the brace to 4 hours, 6 hours, all day, every other day with the brace, finally, no brace at all. If they start to have significant pain, they go back to the brace. And as long as they remain pain-free, they can remain brace-free, but they still have to wear proper footwear in the house, outside the house, and custom foot orthoses at all times. And they, for the most part, 70% of them achieve a pain-free level, and they stay pain-free for years to come, 5, 10, sometimes even a lifetime. But there's not a lot of science there. It's really it's based on the clinician's skill and expertise and communication and trust with the patient to gradually wean them out of the brace at approximately 6 months.
That's interesting, because in a way that sort of advice really sort of sits with again what Peter Malliaras is saying about, when I asked him about complete immobilization, it was the same sort of point. The Richie brace is just a much more quote unquote, not that I like the word, functional brace. So it's not a complete immobilization. It's quite targeted at the deformity that they're suffering, but it's almost exactly the same. You are using symptoms, you're making sure it's stable. If they are having problems, you take that step back. I guess you sort of point towards
I'll quickly add, I listened to Peter, and of course he was talking about a walking boot, which has so many limitations, and it is actually counterproductive to the rehab program. With the Richie brace, we've got full range of motion. The patient can wear standard footwear. They can carry out their activities of daily living. And so the brace is really not an encumbrance to the rehab program. And what's interesting, Alex, is a significant number of patients, when I tell them at 6 months I'm going to start weaning them out of the brace, they ask why. They don't want to go out of it. They say, I'm doing fine. And I say, well, don't you want to get rid of the brace? No, not if it's going to risk a relapse. I'm so happy where I'm at. I'd rather just keep wearing the brace. And some patients, I would agree with them. I said, if that's the way you feel, then keep wearing it.
It's interesting because you point exactly what I was going to sort of pick up on, which is there is somewhat of this black hole in the literature and our understanding on when someone's going to progress, not progress, how do we assess whether the ligaments are going to stable or not? And so what your advice in terms of going into a stable shoe, going into foot orthoses, remaining in these for a long period of time, potentially the rest of their lifetime after this condition has occurred, is that potentially much more about the fact that you don't know who's going to progress and who doesn't, and because it is so debilitating, and because if they develop it again, it risks potential further change to surgery, or it risks having to go back into a brace and start the whole process again? Is that kind of the basis of that advice? Because I guess in some ways, some people might say that's quite excessive, especially if you kind of go, well, you've healed the condition, the ligaments, as you've said, have healed. Why are we being so aggressive on the shoes and foot orthotics?
I think moving out of the brace is really the final stage to the rehabilitation. I think that ultimately we really need to load that spring ligament complex and deltoid ligament, and we can't really do that without moving them out of the brace. So that's my rationale. On the other hand, I'll have to say that I would occasionally have a patient doing very well outside of the brace, but suffer a relapse. And usually it was because they did something silly. I had a woman who took a 3-mile walk down the beach near my practice on very soft sand, and her foot completely broke down after one episode. And despite going back in the brace and even doing rehab, she didn't improve one bit, and I had to operate on her. So a relapse is not good with this. I'm totally aware of that, but I also think that our goal should be to get them brace free. I really do.
Well, that was my point in terms of now that we're out of the brace, and you're sort of just you're saying that we should be in the foot orthotics for the rest of their life, almost, in a way. That was my point? Is that the bit that's sort of too aggressive, or is that sort of leaning into your story there, which is you don't know what's going to happen to who, and that you've seen enough people break down that you're sort of going, I would want them in foot orthotics for the rest of their life, because we don't know exactly, in a way, what caused it, or there might be enough predisposing factors to get that in the first place that you go, it's just too much of a risk, even if
Correct.
it is only 1 in every 20 people that it progresses again.
You're absolutely right. We don't know, and therefore we have to be extra careful with everybody.
Because I guess, I'm thinking about the podiatrist talking to another podiatrist. If there's other non-podiatrist people who don't prescribe insoles listening, you might go, is that a bit aggressive? Is that kind of keeping people in orthotics too much? But I'm guessing in this kind of condition, with what we've seen, it's like you said, it's the risk is almost in a way too high for this, rather than it being, hey, we just want everyone to stay in orthotics and reissue them orthotics. And
I think the risk is very high.
Well, I guess, would you say, because I'm thinking about the risk timetable, those well, not timetable, risk tables, where they sort of say, hey, what's the likelihood of occurring, and what's the outcome that occurs, how it determines risk, is a combination of the two. Something might be very unlikely to happen but could result in death. So that immediately becomes at best, it's still a high risk. Whereas you're in sort of the same point where it's saying it's not super likely, but the impact is quite severe. If it's not caught, it does progress. It does have all those problems, rather than it being very, very likely to occur. That's sort of to clarify.
I like that insight. I think you're absolutely spot on.
Brilliant. In terms of if someone, so we're thinking about the brace, or thinking about a foot orthotic coming out of a brace is probably a better way, because a Richie Brace, you've got quite good guidelines on your website in terms of what you should be prescribing for someone with posterior tibial tendinopathy, adult-acquired flatfoot, progressive collapsing flatfoot with posterior tibial symptoms. You've got quite good guidelines on what the brace should be, and that's going to kind of determine shoe they get, to fit, and what you do. With a foot orthotic though, coming out of a Richie Brace, or if someone is going to try foot orthotics, maybe you have a patient who's in the early stage. What are the features in that foot orthotic that you're trying to really, that you would emphasize? I mean, you've talked before about the medial skive, you've talked about a lateral flare, you've talked about the twisted plate, casting procedure, so you're sort of holding the foot in a specific position to emphasize the arch that you can create with their foot, so you capture that in the orthotic. Are those sort of the key features you would make into an orthotic? Are there other considerations, special sort of people you would do something different in?
Yeah. It's interesting. I would tell you, Alex, the foot orthotic should basically look like the foot plate of the Richie Brace. And a lot of people early on told me they cut the limb uprights off the Richie Brace and just put the foot plate in the shoe for the patient, which actually is not a bad idea, because now they don't have to buy a foot orthotic, at least for that side. But the real problem is if that patient begins to relapse, they don't have a brace anymore.
Yeah,
So,
I was going to say that.
So to answer your question, I would design a foot orthotic exactly like the foot plate of the Richie Brace. I would do a deep heel cup. Now, the Richie Brace has a 35 millimeter heel cup, which is very deep. I think you could get by with a 20, 22 millimeter heel cup. I would definitely put at least a 6 millimeter medial heel skive. I would put a rear foot post, perhaps with a little bit of varus in it, maybe 3 degrees. I would definitely do an extended lateral flange on the foot plate to keep the forefoot from abducting. And then when I cast the patient for the orthosis, I would definitely cast them off weight bearing, and I would pronate the forefoot on the rear foot and plantar flex the medial column. I don't think you have to use excessively rigid foot plate material. I think a semi-rigid orthosis, like a sport, a polypropylene device that would be either 3 to 4 millimeters of thickness, is adequate. I think addressing the needs of the patient in terms of shoe fit and occupation will dictate to some degree the design features of the orthosis. But generally, these patients aren't going to be going back into, casual footwear. They're going to be pretty much obligated to lace up Oxford-style shoes, preferably athletic shoes with motion control features. The shoe fit isn't necessarily going to be as big of a consideration as it is for your everyday patient population, but it should still be taken into consideration. We always make a pair of foot orthoses. People debate that. Well, why do you make a pair? Well, we've always made a pair, I guess I could say in one hand, but there is some validity because we know that some patients who develop adult-acquired flatfoot, it's interesting, the majority of them get the symptoms unilaterally, but many of them subsequently get the contralateral foot will begin to break down within 5 years. Most of the pre-existing pathology that is present in the right foot is present in the patient's left foot, that something triggered one of those feet to begin breaking down and present to you. But it is interesting, the majority of people present unilateral, but in my opinion, they have bilateral pre-existing pathology, so they get bilateral foot orthoses. They don't necessarily get bilateral Richie braces.
Yeah, and I guess I mean, just personally in my own practice, I've always found it hard to just issue one device. People always feel a bit weird, and you spend a lot of time trying to pad their other shoe to make them feel comfortable.
Yeah.
It's only ever worked on one person, and I always say to patients when they ask, I say, look, and that person was had a very odd presentation.
Yes.
In terms of, because it'll be part of your training is surgery, and you're sort of talking about surgery for the condition as well. If we're seeing someone, they've got adult acquired flat foot deformity, progressive collapsing foot deformity. They've got symptoms. They're doing all the things. So they've gone to a brace. They're doing all the rehab, and they're failing to improve. Is there a point? When would we be considering a surgical opinion? And I guess, should we also be considering, are there some people that we should be considering a surgical opinion before we reach that point where they're failing? Like, we can catch them earlier and say, actually, I don't think conservative therapy is for you, or we should have that surgical opinion.
I don't know that I've ever encountered a patient that I didn't think conservative treatment was warranted before surgery. Unless it was a patient who I believe had received good conservative care from another practitioner that I couldn't possibly do better, or other than duplicate it. But that was rare. But I don't think, I really, across the board, I think every patient with adult acquired flatfoot should be treated conservatively and should not undergo surgery until they've been braced. Sure, you can start with a foot orthotic, but you better brace them before you do surgery. In my clinical experience, patients who are going to fail our treatment program with AFO bracing and rehabilitation, they show their signs early on. They do not get initially better. They do not get pain relief within the first 4 weeks. They get very little, if any, pain relief with 4 weeks. They just don't progress. They don't respond, and they don't progress. Some of them will respond if you temporarily immobilize aggressively in a walking boot or even a short leg cast for 2 to 4 weeks. I will sometimes do that, then put them back in the Richie brace. But if they're not responding in the first 4 weeks, generally, they're not going to get better. I learned that early on. I would still try, but I would already myself be preparing and telling them, I think you're going to be having to face surgery. I want to keep trying stuff. I'm going to put you in a cast for a little while, but you're just not responding like 70% of other patients do. And we don't know why, Alex. I mean, it's not, again, based on severity of deformity. It seems like there's multiple factors, and some people heal and some people don't. You know that.
I appreciate that. Because some people could look at that as, oh, that's anecdotal, that's not scientific based. But I think some of this sort of thinking is really scientific based, because it is looking at the available information and going, I'm not going to overemphasize. I'm working with the information that we have, and the information we have is not good, and so we're having to be protective, or we're having to make these sort of decisions. And you're not jumping to, oh, you haven't responded in the first 4 weeks. You're still going, we have to try. But you're dealing with that human element of it as well. And I think that's sort of something that's sort of permeated sort of through, is that, whenever we've sort of tried to talk about something, you've been like, and actually, this is how you handle the patient. And actually, this is what you need to be telling them. And actually, this is what I'd be preparing them for. It's this, that component of it, because that is what we're dealing with. We're not dealing with pure biomechanics. We're dealing with humans, and when we have that physiology sort of focus, yes, some people do get better and they don't, and we don't have a blood test or a scan or a something that tells us. So a lot of this advice is sort of steeped in patient management and that sort of years of managing people. So I do like that approach quite a lot. I think it's that art component of it, which is still technically, if you look at it, a science, because that is the scientific method. But we won't. We don't need to go down that path. One of the things that you were talking to me about before we started recording was when and this sort of goes into actually what we talked about as well when we were actually recording, which was about orthopedic surgery and how the classification systems were really focused on initially, rather than a dynamic understanding of foot, it was a static understanding of the foot. And there's a focus potentially in orthopedic sort of surgery training on the static foot and correction. When it comes to doing a surgery and it comes to referring people for a surgical opinion, what are you looking for in a surgeon to say they sort of understand this a little bit more, that there's a dynamic instability, and that the surgical operation needs to sort of reflect this? Like, how do you go about that potential difference between, in many countries, having a podiatric sort of surgeon that is very well trained, very understanding, does do the conservative sort of treatment and then sort of follows it through to someone who's just doing surgical treatment and might be missing some of these pieces?
Yeah, well, I can tell you as a surgeon myself, the technology has taken quantum leaps over the past 20 years in our ability to provide good procedures that have better outcomes with less disability. And I think that making a referral, for example, as a podiatrist in Australia or in UK to a qualified surgeon, you have to refer to a surgeon who primarily only does foot and ankle surgery, because they will stay up on these newer procedures and newer technologies to a much greater degree than a general orthopedic surgeon would. You would need to refer to someone who does a lot of these surgeries. There are a lot of podiatrists in the United States who do a lot of bunionectomies, but they don't do a lot of flatfoot reconstruction. Um, so you really need to find someone who is at the cutting edge, so to speak. The general trend is to avoid fusions. In the old days, the only procedures that really worked were fusions, whether it was a full triple arthrodesis or isolated fusions, primarily of the talonavicular joint, because those procedures directly addressed ligamentous rupture. The thought was, well, if the ligaments rupture and the joint's unstable, the only way to make the joint stable is to fuse it. And so that's what they
Yeah.
did. The problem is fusion procedures in the hindfoot are difficult to perform. They're very difficult for the patient to recover from. And particularly on the typical patient of adult acquired flatfoot who's over the age of 50 and usually has other comorbidities, these are just very risky to undertake. Happily, we've developed new technologies to enable us to do osteotomies at various bones and realign bones, and then use orthobiologics and other things to encourage ligamentous repair. And one of the most fundamental breakthroughs was the development of a spring ligament repair known as the internal brace, which was developed by a company called Arthrex here in the United States. And the internal brace allowed us to, they say, to augment a repair of a spring ligament, but it literally does anatomically reproduce the spring ligament with artificial material. But you still need to use biologic tissue around it to fully reconstruct and develop a functional ligamentous complex. But with the advent of that technology, I think we can avoid fusions anywhere in the foot, and with a good operative technique, get the patient back much sooner with a good functional foot that hopefully will hold up for the rest of their life.
It's interesting because when you talk about that, the thing that I think about, and sometimes I've explained it as this way, I'm not sure if it's correct or not, but in a way, a lot of these advanced procedures are much like, how are we doing an internal orthotic or an internal brace, where it's figuring out a way to address those bony sort of changes and joint changes that has predisposed them to the collapse, and sort of stabilizing the ligaments and helping them either repair on their own or physically actually getting in and repairing them. Is that sort of a good way to sort of explain it, that we're trying to do things externally, but we know orthotics, the way people move on them, there's a large variance in how people respond, which again, we don't know why there's such a variance. There are consistent patterns, so we can say, this is what we should do with an orthotic in terms of features, but the individual response is individual. Is that a good way to explain it to people, where it's kind of like, we've tried the external brace, now we have to go to the more sort of internal sort of components to try and address those factors?
I think that's hopefully where surgery has now evolved, is that it's addressing internally the biomechanical changes that we try to address externally with the foot orthosis. Yes.
Hmm. Oh, good. It's always sort of good to go. I haven't been my external view of it hasn't been too far off the mark,
Yeah.
at least. One of the things that we sort of you've touched on, and that I know it's quite big. It's quite sort of it was a big shift in my management when I saw you speak. I think it was 2017 when you came out to Australia last. Is the lateral flare in an orthotic. So this is bracing down, or I think you call it lateral flange. It's this sort of essentially holding continuing the heel cup, the lateral heel cups are on the outside of the orthotic, sort of continues forward into the lateral aspect of the device, essentially acting like a barrier on the outside of their foot, specifically for this condition. Whereas a lot of people, especially up to that point, what I would have been doing is putting a medial flare in, so putting it because their foot is collapsing, it is flattening, it is getting wider on the inside of the foot, and we'd go, well, we need to put a flare or something essentially to hold that middle of that foot, the medial aspect, together. Can you explain the reasoning behind why a lateral flare is much more appropriate than a medial one?
Sure. And by the way, we use the term flange, but flare sounds good to me too. But basically,
Yeah.
we're talking about extending the wall of the orthosis distally
Mm.
from the heel cup, really, all the way out to almost the end of the orthotic. So um, the preface to this is that if you look at there's about 5 really good kinematic studies of patients with posterior tibial tendon dysfunction that are published in the literature. And every study shows that the most significant change or gait change is abduction of the forefoot on the rear foot during dynamic gait. Compared to healthy controls, patients with adult acquired flatfoot show excessive transverse plane abduction of the forefoot on the rear foot. Interestingly, frontal plane eversion of the calcaneus is one of the most minimal changes we see kinematically. Dorsiflexion of the first ray on the rear foot and dorsiflexion of the entire forefoot on the rear foot, meaning sagittal plane instability of the midfoot joints, is the second most dominant change. So we want to prevent that forefoot abduction by putting a wall or a blocker up against the shaft of the fifth metatarsal to keep the forefoot from abducting. That's the simplified way to look at that.
Mm.
The medial flare does make sense and is a very common and long held orthotic intervention for flat feet in general because it increases the surface area beneath the midfoot joints medially and along the medial arch, which makes sense in terms of sagittal plane control. The problem is if that platform under the medial column of the foot begins to wrap up around medially along the medial cortex of the first metatarsal and the cuneiform, it can actually now provide an abductory force. It prevents the foot certainly from adducting, and depending on the slope of this medial flange, it creates a ramp-like effect that the foot tends to slide off of. It tends to. You have to be very careful. If you have an orthosis or a Richie brace with a deep heel cup, you already have a very wide foot plate. The foot plate is going to extend well beyond the bisection of the first ray. It's going to cover most of the plantar surface of the medial column anyway. But as you begin to wrap it up medially in a true flange, now you're creating a ramp-like effect that, if anything, just abducts the foot. The patient tends to slide off of it. And that's the worst thing you can do in an adult acquired flatfoot. So I have learned over the years, you just don't need to and don't apply a medial flange, but always apply a lateral flange, and the results will predictably be better.
That's interesting because you're essentially saying we're already doing a medial flare to a certain extent with the deep heel cup, because the higher you make a heel cup, the wider the device is already. So you're already kind of doing enough if you're doing a deep heel cup, but it's that wall that you need and stopping that abduction. And I guess that's sort of the distinguishing feature of potentially managing someone with a flat foot, maybe without unacquired flat foot deformity, without this abduction, this, for a lot of people, too many toes sign that you see when they're walking. They are quite straight. Their foot's not abducting, then maybe that medial flare has been working, or it might be a reason why that has worked before for people, but why, it's not going to work in this case. Is there anything that you do to make that lateral flare more comfortable? In terms of, because I have had, being quite a fair bit younger, seeing you talk, I was like, great, everyone gets lateral flares, and it worked quite well, but there were a number of people that had a lot of irritation. So if we're thinking of podiatrists listening, go, how people are going to get used to that. I've started putting, the lab to accommodate the styloid process. They put a little bump in the shell itself. Sometimes we might use some padding, so you've got that accommodation and some padding around it as well. Is there anything else that you would be thinking about or doing or asking the lab when you're ordering that to potentially make it less irritable or less likely to irritate?
Well, it's interesting. Lateral flares are really risky with healthy feet. It's very interesting that most adult-acquired flatfoot do not have a prominent styloid process because the forefoot is already abducted on the cuboid, so the styloid has disappeared. If you can envision, the forefoot is rotated. So I rarely had problems with styloid irritation in any patient with adult-acquired flatfoot. If the lateral flare was to irritate the foot, it usually was more distally, and it was really if the lab inadvertently extended it too close to the fifth metatarsal head, because there it's really going to bother the patient. It should never extend beyond the anatomic neck of the fifth metatarsal. It should never touch the actual head of the fifth metatarsal. When in doubt, a lot of labs will allow you to put on what's called a lateral, we call it a flip. But instead of making the lateral flare out of polypropylene, instead of having the foot plate assume the shape of the flare, you have the lab simply construct a flap of material. Usually it's Corex or dense EVA material. And it's glued and folded onto the orthotic surface and bent and heat molded into a kind of a curved shape. But the bottom line is it's softer and more forgiving than polypropylene. Now, I rarely had to do that, but if I ordered a polypropylene lateral flange and the patient didn't like it, it was really irritating, I would just grind it off in the office, and I would glue on a piece of Corex and make a flap out of it right in the office setting, and not have to send the device back to the lab. But I'll be honest, Alex, that was always a rare occasion.
Okay. I think potentially younger Alex was maybe a bit too liberal with the lateral flares. Scared himself.
Well, what's interesting, Alex, is lateral flares, I'll tell you, across the board, probably in Australia, and I know in the U.S. in podiatry, are used for cavus feet. For the same rationale that we use medial flanges on flat feet. And a lateral flange on a cavus foot is the worst thing you could ever do for a cavus foot, because it's the cavus foot that always has a prominent styloid process. That's number one. Number two, a lateral flange inverts, it adducts the forefoot. And in a cavus foot, that's the last thing you want to do. A lateral flange tends to supinate the whole foot. It's the worst thing to do. When I treat cavus feet with a Richie Brace or with a foot orthotic, I use a medial flange. The patients love it. The minute they step on it with a medial flange, they feel that pronatory force on their foot, and they feel that total relief off the lateral column. And you use a lateral flange, all you're doing is just jamming that lateral column and adducting the forefoot. And you're irritating the styloid process, which is already overly prominent. So we need to reverse that whole paradigm.
It's very much like when we understand biomechanics. I mean, I've always been something that goes. I think biomechanics in a way is almost too simple. We want it to be complex, but then the way a lot of people practice is they go flat foot, tilt it one way, high arch foot, tilt it the other way, and sort of classifying things really sort of in their minds based on how they look, not on how they function. And I think that's exactly what you're highlighting when you're going, actually, functionally, these are different. And I guess that one of the things that I noticed in your book, to sort of go to the point of the forefoot abduction, and one thing that you commented as well when I put out my post, talking about posterior tibial tendinopathy and movement, was that the posterior tibial tendon has a adductory role in terms of its force moment arm. So it part of its, what you're highlighting is from I can't remember who the work's from, but you would sort of, it has a role in adducting or pulling that midfoot out of abduction. And so in a way that if we're thinking about symptoms as well, being able to control that movement and reduce that movement of abduction, you're deloading the posterior tibial tendon in a way as well. Is that a correct understanding?
Yeah, as a surgeon, early on, I had the great opportunity, when I was doing ankle surgery, I would always reach in and tug on the tendons around the ankle because I always liked to watch what it did on the foot. Uh, you folks can do that if you have access to a cadaver lab. And I wish that if I were teaching biomechanics, I could take every student into a cadaver lab. And one of the most visually compelling experiences you can have is to hang a foot off of a table or rest it lightly on a supportive surface and pull on tendons and watch what the foot does. And having pulled on a posterior tibial tendon on a lot of feet, you watch what the foot does, and the foot adducts. Visually, you don't see, quote, inversion of the foot. What you see dramatically is adduction of the forefoot when you pull on the posterior tibial tendon. You hardly see any frontal plane movement, a little bit of inversion. But as I showed in my book, the moment arm of the posterior tibial tendon in the direction of adduction is threefold the moment arm for inversion. And in fact, the moment arm of the posterior tibial tendon for pure inversion is just about identical to the tibialis anterior. They both have about the same moment arm for pure frontal plane inversion. And so, I think there's too much emphasis placed in academics and in surgery that the posterior tibial tendon is a inverter of the foot. I don't dispute that it indirectly is an inverter, but it's not directly a powerful inverter. Its primary role is to prevent abduction of the forefoot on the rear foot during the stance phase of gait.
That's it's an incredibly interesting sort of thing, because then it kind of really does sort of nail down all of those points that we're sort of talking about. Kinematically, adult acquired flat foot progressive collapsing flat foot deformity is, that kinematic change that you see most commonly is that too many toes sign, that abduction of the forefoot, or for other people it would be one other way of thinking about it is external rotation. And that external rotation abduction is a component part. Like we always get told, pronation is a triplanar movement. It's you're getting the eversion as well as the dorsiflexion and abduction. So it kind of still makes sense. It's just that's the sort of more of the keystone or the key part of that. And if you can control that, it sort of has all the other effects, because your foot can't evert as much if you're not getting that abduction. So it's kind of, it all becomes like a nice sort of loop in a way of understanding.
Keep in mind the tibialis posterior, the posterior tibial tendon does not insert on the calcaneus. It does not insert on, it has no ability to directly supinate the subtalar joint. It acts at the talonavicular joint, and it acts across the mid-tarsal joint. But it does indirectly supinate the subtalar joint by bringing the metatarsals medial to the subtalar joint axis in the transverse plane, such that ground reaction forces are more likely to supinate, retrograde the subtalar joint. So it
Mm.
has an effect on the subtalar joint, but certainly in open kinetic chain, it has almost no effect on it. And patients who have ruptured their posterior tibial tendon show very little change in calcaneal eversion. They show what you just said, marked forefoot abduction, because that's what the tendon does. And really,
Mm.
my point of sharing that with you, Alex, is, and Cornelia Kulig underscored this, the rehabilitation program in terms of muscle strengthening should focus on the transverse plane. These patients should be adducting both concentrically and eccentrically the foot to either rehabilitate the injured posterior tibial tendon or recruit and strengthen those other tendons, principally the flexor digitorum longus, who have some moment arm of transverse plane adduction. But focusing purely on inversion, eversion is really missing the boat and is not going to recruit the tibialis posterior, as Kulig showed, and certainly is not going to functionally move the foot into the direction of range of motion that we need for a proper rehabilitation and tendon recruitment.
Amazing. I think that's a brilliant sort of point to end on, because we've sort of come right back around full circle, and I think wrapped everything up quite quite nicely. My question to you before we end is there anything that you think that we've missed in this discussion, or that you'd want to add or talk more about?
I really want to emphasize, particularly for the Australian audience, that contrary to what the surgeons may tell you, conservative care, particularly with bracing, not just with a Richie brace, with many forms of AFO braces, is successful 70% of the time in patients with stage 1 and stage 2 adult acquired flatfoot. It is incumbent on you to initiate conservative care. Don't let the surgeons tell you that every patient's going to end up eventually needing surgery. That's just not true. There are multiple papers published around the world that completely refute the notion that these patients all will eventually require surgery. It's actually quite the opposite. And so, as a well-trained biomechanist, podiatrist who understands their principles of rehabilitation, you're in the perfect position to help these patients much more than a surgeon who doesn't understand biomechanics and surgical intervention. And so you have a great opportunity there to help a patient and gain a patient who will be your friend for the rest of your life.
Mm. And I guess it's not highlighting that. I guess we don't want to stoke the any sort of anti-surgeon rhetoric, but it's very much just about saying in this condition we can do a lot more conservatively than previously thought, because it is a new condition. And as with everything that happens, in medicine we always go very aggressive to start with, the whole, go hammer and tongs and really do everything that we can. And then over time, we're learning actually we can intervene less and less and less. And now we're sort of at that point of that curve where we're figuring out it's quite safe and effective to manage them conservatively. We're avoiding potential harms of surgery, but there is still enough people that we do end up there, as you've said, just to sort of preempt any sort of point, especially if we put this as a clip on on social media.
I don't mind if you do.
We'll direct all the flack to you.
I'm happy to take it.
So if people wanted to find you, your work, the more about the Richie Brace, I know you've got some videos and things out there on twisted place casting. So talking about the casting technique, talking about some of the things that we've talked about more like visually with the with orthotics. Where would they find that information? Where would they find more about you?
Well, two places. First of all, in Australia, QOL has a website. I believe it's richiebrace.au. which you can and I think most of my videos are on there. You want to look at that, Alex?
Yes, I do.
And
I'm
then,
looking at that.
and then there's a website that we have here in the United States that's richiebrace.com, and it has a plethora of educational materials, um, uh, videos, articles I've written, etc. And then you can message me on that website directly, and I always answer the messages within the same day.
Yeah, so the website for the Australian website is richiebrace.com.au.
Okay.
And yes, has all of the orders of braces, and actually has as well a patient website as well, like that you can show them.
Yeah, it's very similar to our USA, and it has all the educational materials for both the patient and the clinician.
Mm. And a nice casting video I can see with you with a moustache.
Yeah, that was quite a few years ago, Alex.
It's a nice blast from the past. Amazing. Thank you so much for joining me and your time this morning for me, this afternoon for you. And thanks everyone for listening. If you do have any questions about the podcast, what we've discussed, you can contact me and I can pass them on to Doug. We can share it on social media and get some answers, or you can obviously, if you've got some really good technical questions you want to do a Richie Brace or an orthotic, you can get in contact with Doug directly through his website. But thanks again for joining us, and we'll see you in the next episode.
Thank you.